عليكم ورحمة الله وبركاته. Assalamu alaikum wa rahmatullah wa barakatuh. Hello everyone and welcome to our webinar. My name is Noor Al-Mad'aj and I am an occupational therapist from Kuwait, specialized in neonate and early intervention, and I'm the founder of this group, Occupational Therapy Support Group and Resources. So today's webinar titled with Hand Therapy Basics in Times of Need, equipping occupational therapists to treat upper extremities condition, presented by Dr. Fatima uh, Adamu-Good. Am I right? Yeah.
Yeah, that sounds good.
Okay, good. Dr. Fatma's 19 years of experience. She's an occupational therapist and certified hand therapist. She's an adjunct professor in Thomas Jefferson University. Hello and welcome.
Thank you. Hello, everybody. Thank you so much to Nora for having me today. Um, I have been a hand therapist. Well, I'm an occupational therapist who specializes in treating upper extremity conditions or hand therapy. I've been practicing as an occupational therapist for 5 years now. Prior to that, I was a yoga teacher, specializing in adapting yoga to people with injuries, so spinal cord injury, traumatic brain injury, amputations. So I've been thinking a lot about accommodating injuries and different levels of disability for a long time. And I have been teaching hand therapy skills, so splinting and hand therapy anatomy for about 3 years now, since 2020. I actually started during the pandemic, virtually and in person. So I'm very excited to share the content with you today and to see if I can be of help as some of you prepare to treat these conditions. Okay. As Nora mentioned, the lecture is called Hand Therapy Basics in Times of Need, equipping occupational therapists to treat upper extremity conditions. This could apply to occupational therapists and physical therapists, actually, because both specialties think about treating and adapting and improving the state of people's ability to function. So I hope that you are all able to apply this information. The objectives, oops, 1 second here. Oh, there we go. Let's go back. Objectives of this lecture will be to equip attendees to treat upper extremity conditions and to treat specifically traumatic injuries, amputations, burns, crush injuries, which can involve several different structures in the body, and also to empower you to develop creative splinting and immobilization strategies. I didn't want to assume that you would have access to regular thermoplastic materials in an area where there's not a lot of access to many supplies. So I tried to focus on the essential principles and basic biomechanical and anatomical ideas that you want to keep in mind when treating these conditions. Can everybody hear me okay so far?
Yes, clear.
Okay, great. So I wanted to share a disclaimer that this presentation is not meant to cover the complexity and the breadth of all upper extremity conditions or treatment options. This is simply a broad snapshot of what could go wrong, basically, and to provide you with a jumping off point so that if you have access to an ability to research more information about these conditions, you can do that. But hopefully I can help you kind of troubleshoot in the moment conditions that you might be seeing. What is hand therapy? Hand therapy is the art and science of rehabilitation. Hand therapy includes the upper extremity, right? So from the shoulder to the hand, that's what I specialize in. And it is a combination of occupational therapy and physical therapy. It's very orthopedically based. So in my treatment of patients, I do wound care. I will take out sutures as I work with surgeons. So I will either stabilize patients before surgery, right? Because we're trying to get the um, bones and nerves and tendons into a good position, or I will see them after surgery to make sure that the wound is healing appropriately, to make sure that it doesn't get infected, and in addition to showing them exercises to increase joint range of motion and strength. Okay. So I wanted to review the upper extremity anatomy. I want to see if I can move this bar down. There we go. Okay. All right. So, whoops. Okay. So anatomy of nerves. 1 second here. Enter. Yep. Upper extremity nerves are pivotal. In this slide, you will see the shoulder you could consider as encompassing the collarbone or the clavicle here. And then there's the shoulder blade in the back there. And then you have the humerus bone going down into the ulna bone here and the radius bone here. So hand therapy encompasses everything you see in this picture on the left-hand side. Sometimes we end up dealing with the cervical spine or the nerves and muscles of the neck because the nerves that come out of the spinal cord feed the arm. And so you end up dealing with some spinal cord issues as well, although physical therapists are usually more equipped to deal with those. On the right-hand side here, you can see sometimes the zones of the arm are broken up into zones that the nerves influence. So from the neck, right, the C would be cervical spine, and depending on which level of the cervical spine the nerve is coming out of, you could start to troubleshoot aspects of the arm and hand that are being influenced by neurological issues coming from the neck. This also mentions the thoracic spine, so the nerves that feed the arm coming from right below the neck here, going into the upper back muscles. Okay, so mechanisms of injury for the upper extremity, and I was trying to think specifically of times of war, times of crisis. Could be a fall. Sometimes I have patients who fracture things just from falling, walking down the street, right? Much less running in a time of crisis. So fractures from falls, impact of a heavy object falling from above, burns could be electrical, chemical, or fire. Crush injury, heavy object could be falling on you, could be a piece of machinery that runs over the hand or the arm, involves multiple structures. So it could involve bones, ligaments, tendons, nerves, muscles, blood vessels. Blast injuries would also be complex. Also laceration, sharp object, broken glass, sharp pieces of metal, and flying debris as well, for example, from a bomb blast. Okay. In order to truly treat, or for optimal rehabilitation outcomes, we want to make sure that we're reaching these conditions and starting to address them early, right? And also applying the right protocols. Yeah, and also the right type of immobilization, which is why I sometimes end up seeing patients before surgery, because the surgeon wants to stabilize them and make sure that they don't injure the structure further. For example, I had, let me pull up my video here. For example, I had a patient come in recently who was a firefighter, and a piece of glass fell on his hand, and so he injured his extensor tendon. So this is his hand, right? So he's not able to extend at all. And the surgeon wanted me to place him in a splint that would keep his tendon straight, because he doesn't want, you can see, I'm trying to exaggerate here, you can see these lines are my extensor tendons. The surgeon didn't want the patient to end up, trying to make a fist and further injuring his tendons. So I had to place a patient like this until he had surgery about a week later. So if that patient had not gotten positioned at the time that I did, that would greatly impact his ability to, in the future, straighten his fingers, and also which would affect his ability to reach for objects. And over time, everything would just kind of get stuck like that. And then you end up with a hand that is not functional, except for maybe these fingers. Surface anatomy review. It's helpful when you are looking at the extremity to just be able to identify landmarks, right? So as I mentioned in the nerve slide, we have, whoops, a moment here. As I mentioned in the nerve slide, we have the collarbone there. These are the trapezius muscles that would help to elevate your shoulders. We have the deltoid muscles here that helps to lift the shoulders up. Lift the arm up rather to the side. We have the pectoral muscles. You use them when you reach the arm forward. Bicep muscles for bending the elbows. Here we have the flexor muscles, which people use for flexing their fingers or flexing their wrist. Along the back, right? So this would be on the back of this arm, we have the muscles that would extend the wrist or straighten the fingers. Those extensor tendons I mentioned earlier. And then now we have the hand. The thenar muscle here, where the thumb is an important muscle because the thumb does about 40 to 50% of the work of the hand. So, for example, if I were to see a patient with a very flat thenar, so sometimes, the thumb looks like this, very collapsed, or all of this kind of fleshy bit looks very flat, that would tell me that the median nerve, one of the nerves of the upper extremity, is affected. And that would give me information as well. So learning to kind of read the upper extremity can be a very useful tool. Okay, so going back to nerves, the nerves are pivotal in upper extremity function. They're like the electrical supply, right? If you don't have electrical supply and energy, your muscles don't really have much ability to work. So the function of the nerves would be to interpret the environment, and to give the patient information. So if you touch something sharp, you get pain, or if there's something wrong with your body, you feel pain. But for the peripheral nerves, we're dealing with the nerves of the arms and legs. I'm going to focus on the arms. Temperature, if something's too hot, texture, vibration, and muscle activation. So as I mentioned, the juice that you need to do your daily activities. There are three main nerves that feed the arm and hand. Radial nerve, which does elbow extension, as I mentioned, so elbow extension, wrist extension, finger extension, and also supination, so your ability to rotate your palm up. The median nerve, finger flexion, feeds these three fingers specifically, as well as that meaty part of the thumb I mentioned earlier. Also feeds half of your ring finger, this finger number 1, 2, 3, 4, half of that finger. And then the ulnar nerve feeds half of this finger, and also the pinky runs through there. So if you see a patient with a flat hypothenar area here, so this is the thenar, and this is the hypothenar. If you saw a patient with a flat hypothenar complaining of tingling in these fingers, that would cue you into an ulnar nerve complexity or injury versus median nerve, which is these fingers and half of that one. Okay. Peripheral nerves So here I have just, a map of, so we have central nervous system, brain, spinal cord, brainstem. It's helpful, to think of it as just a central area. Brachial plexus is those network of nerves that feed into the upper extremity. So as I mentioned before, radial, median, and ulnar. There is also a musculocutaneous nerve, but for the purposes of this lecture, I wanted to keep things very simple. And in my clinical practice, I focus mainly on the radial, median, and ulnar nerves, right? You're welcome to research musculocutaneous nerves if you want, but I find it helpful to keep things simple. Nerves are very sensitive to, let me shift this over here. Okay, nerves are very sensitive to traction. So if you were to stretch, for example, if somebody's arm were to get pulled, if somebody's arm is trapped under a piece of debris and they're trying to free themselves, that could traction the nerves of the brachial plexus, which come out through the neck. They're also very sensitive to pressure. So sometimes, if somebody were to be unconscious for a long period of time and to have their radial nerve, which runs through the humerus here, if that were to get compressed for a long period of time because the patient is unconscious and not getting assistance, that can lead to the radial nerve being injured, and then you might get a patient who just cannot extend their wrist at all. Right, I'll go into more detail of that. So traction and pressure. It can be helpful that the nerves are elastic and can, stretch when you stretch, but there's a threshold at which there's too much. Okay. Central nervous system versus peripheral nervous system injuries. Again, as I mentioned, the brain is composed of the central nervous system is comprised of the brain and the spinal cord. And again, I'm keeping things simple. And the peripheral nervous system, I'm going to focus here on the nerves that come out from the spine and feed the upper extremity. Simplistically, when you're looking at somebody with a central nervous system injury, so if you're trying to figure out, what's going on pretty quickly, the central nervous system, you might see a lot of spasticity in the upper extremity. So it's a lot of kind of tension and sometimes just really jerky movements, if there is movement at all. Things are fairly stiff and rigid. The person can also be weak. When you're dealing with a peripheral nervous system injuries, it's ones that are involved kind of full laceration of the nerve, or compression for such a long period of time that the electrical signals do not reach the muscles, then you deal with a lot of flaccidity, a lot of the atrophy, like the flattening out of the thenar and hypothenar, as I had mentioned. Also dealing with muscle weakness, but the presentation can be a little different, right? So very spastic and rigid versus very flaccid and not much tone because the electrical signals are not getting through to the muscle. Okay. Mechanisms for peripheral nerve injury, laceration, right? So the nerve either being cut completely or partially by a sharp object, compression, as I had mentioned. So the Saturday night palsy or radial nerve palsy is what I was talking about, where the wrist is completely weak. Chronic compression, carpal tunnel would be, so that's more of a repetitive thing, right? If you have somebody who's doing the same task for long periods of time. Compression can lead to, eventually, over time, can lead to complete sensory and motor loss if you're not catching the condition early. So if, for example, with radial nerve palsy, the doctor will ask us to place the patient in a splint that extends the wrist, and you're basically waiting. This is in a situation where the nerve is still intact, right, and it's merely compressed. You're placing the wrist in a extended position and waiting for the nerve to regenerate. Oftentimes the splint will also include the fingers, right? If you look up a radial nerve palsy splint, you will see a variety of different designs of that. Carpal tunnel, you can also help address by placing the patient in a position where the wrist is neutral, right? Because the carpal tunnel involves a median nerve and that comes up through the carpal tunnel through here. So if the patient is usually sleeping like this or in position, in situations where they're very cramped, you can kind of alleviate that tension on the median nerve by placing the patient in a neutral wrist position, right? So zero degrees of extension versus 15 to 25 degrees of extension for a radial nerve issue. Another way that the nerves get injured, again, as I mentioned earlier, too much traction, too much stretch. The extremity gets trapped somewhere and you're pulling, trying to free the person, and they end up with an injury. Those are often, not always, often time waiting for the nerve to recover from that amount of traction is a good bet. And in the interim, usually providing the patient either with a way to immobilize the arm. So with a sling, further in the lecture, I talk about how you could make a sling out of materials that you have, and kind of letting the arm heal and giving the patient some exercises is useful. Okay. Classifying peripheral nerve injuries. I'm not sure how useful this information would be. I did think it would be helpful to just show the continuum of nerve injury complexity. Again, just to give you a framework with which to classify the injuries that you might be seeing. So with neuropraxia, you would have pain, no muscle wasting, which I know I mentioned, right? So, there's different levels. Weakness, numbness is common, proprioception issues, so ability to kind of figure out where your arm and hand are in space and to engage with your environment. So kind of the person might seem clumsy because they're not quite able to engage and give all the interpret all the information, sensory information that the extremity is getting. With axonomesis, you have pain again, muscle wasting in this case. So that's when you start to see that loss of muscle mass. You get motor sensory loss. You can also recover completely, again, time sensitive. With neurometis, there's no pain, which can be tricky because pain is a good signal, right? Pain tells you something is wrong. And with nerve injuries, it can be tricky because if there's no pain, people tend to think, oh, everything's fine. Maybe they're just a little weak. But unfortunately, that's not the only metric. You still want to look for things like muscle wasting, things like, are they able to detect sensation, like if something's soft, is something sharp? And just using that as a red flag as well. So no pain doesn't mean no problem. It could mean that you have a more complex nerve injury. Peripheral nerve healing. If the nerve is not completely lacerated, it is possible for it to recover. Nerves are notoriously slow to regenerate. On average, damaged nerves can grow back at a rate of about 1 inch per month or 1 millimeter per day, although a lot of times it seems even slower than that when you're dealing with a situation where you don't have a lot of sensation or function. So that it can be very frustrating for the patient because you're just waiting and hoping. Also, I forgot to mention with nerve injuries, the pain nerve fibers are the first to regenerate. So sometimes people go from zero sensation or from numbness to sharp pain. I had somebody experience this yesterday, and then they get very concerned because, pain is a red flag, but it can be a sign that the nerve fibers are regenerating actually, and pain is the first to return. So that is very important to keep in mind. Signs of peripheral nerve injury for the 3 main nerves that I'm focusing on today. For the median nerve, numbness and tingling in digits 1 through 4, so 1, 2, 3, and then half of 4. Remember, ulnar nerve is half of this, and that one. So if a patient is saying they have tingling, my first question is, which fingers? Atrophy at the web space, so it could be atrophy in this web space here on the thenar. Inability to bend the tip of the thumb, so for median nerve. hand pain at night, grip weakness, lack of wrist flexion, loss of thumb opposition. So opposition is your ability to kind of bring your thumb over and reach for objects. Radial nerve would involve wrist drop, as I mentioned, again, loss of wrist and digit extension, loss of elbow extension, tingling, burning, numbness. So tingling and numbness are kind of classic nerve injury signs to watch out for. With the ulnar nerve, tingling, numbness in digits 4 and 5. So again, half of that one and that one. Clawing in fingers 4 and 5. So that would look like that. Inability to spread fingers apart. So patient's abduction will be very weak, and then their ability to, spread the fingers and reach for objects is impaired. Also, the ulnar nerve actually runs up through, so the carpal tunnel is here. The ulnar nerve needs to run up through this pinky side and go through a little canal here and loop over and help with some thumb function, including key pinch. So a pinch where you're pressing down like that. So if the patient has an inability to kind of apply that key pinch, right? And also you notice tingling they complain of tingling on this side of the hand, or you notice a clawing, then you know that you're dealing with an ulnar nerve situation. Okay, functional impact of peripheral nerve injuries: impaired grip ability and strength, pain, fatigue. So because the electrical signals are not at full amplitude, people run out of energy very quickly when they're trying to use their hands for everything, getting dressed, taking, childcare, making meals, loss of dexterity and fine motor control, also related to the fatigue, because you just don't have the energy and the electrical signals to fire, juice up the muscles. And as I mentioned, reduced competence with ADLs and IADLs, and then that also impacts the patient's psyche because, they're not able to do what they need to do. So one way to take care of peripheral nerves when there's not a complete laceration is to perform nerve glides. I'm going to shift this over here. So a nerve glide or a nerve floss is a slow, controlled, purposeful movement using the body parts that are attached to the affected nerves. The movement is designed to wake up the nerves, give them blood flow. So nerves are sensitive to blood flow. Bones are also sensitive to blood flow, and blood flow affects fracture healing. We'll get to that later. And then helps that when you floss the nerves or glide the nerves, helps them to stop sending pain signals, helps to alleviate some of the numbness and tingling, and just helps the nerves become happier. So up the top here, I have, I'm going to focus on the self-flossing. So for the radial nerve, in this situation, we're extending the elbow, and then we're kind of flexing the wrist in and turning the head the opposite way. These are going to be very broad because I'm hoping that you would be able to look up this information in order to address these conditions. In radial nerve situations, oftentimes the back of the hand, especially this thumb side of the hand, the patient would complain of pain or tingling in that distribution to back of the hand. Median and ulnar nerve, it's mostly the front. So median nerve glides. There are some that involve the hand more specifically. This one shows a full arm version. Then ulnar nerve. There are quite a few. This is one that involves kind of rotating the hand. That can be a tricky one to do. There's a really simple one that I like to teach my patients, which you will find, if you look this up on the internet, which is I start with my wrist flexed, I extend the arm, have them extend their wrist out, and then pull in. I find that to be a much easier one to do because honestly, my arm is not able to do this one down here. So that's not one that I teach. So there are options that you can research and find what works for you. You're still addressing the condition. It doesn't have to look exactly like what I have here, or the first things that you might find on the internet. Okay. Another aspect of hand therapy that I mentioned that I address is wounds. Okay. And wound healing, wound care, it's very important to think of the phases of wound healing, right? Days 1 to 3, when the wound is fresh, you're primarily dealing with stopping bleeding, right? And then days 3 to 20, you're dealing with a lot of inflammation because, you know, the area swells up because your body is like, let's heal the area, sending a bunch of fluid to the site, protein-filled fluid usually, just to try to wash any infection out of the site and to heal it. And then during weeks 1 through 4, that's when you start to see the scabbing and layers of new tissue covering up the wound. And then wounds continue to heal for up to 2 years, right? So a scar, if a patient has a wound that closes, the scar can be forming for up to 18 months. So just because a wound is closed, when you see it in the first month or two, doesn't mean that's done healing and modeling. So there's still ways that you can address the wound, because a wound that closes and a scar that's tight can affect joint motion. So if the wound closes and we don't educate the patient on how to like massage the wound, it starts to affect their ability to use the hand or arm. Okay. Wound care elementals. Wounds need to be clean to avoid infection, moist to encourage epithelial cell migration. So in order for just the transfer of the correct cells and molecules to the site to do what they need to do. If the wound is dry, it kind of stops that healing process and you get a wound that like stays open for longer. But then again, too moist means that the skin breaks down and there's poor wound healing. If a wound is too moist, it's often kind of gray looking. It stays, you'll notice that it stays open for much longer. And our inclination usually, as patients and as clinicians who are not as familiar with wound care, is to cover it up, right? So we say, oh no, we need to cover the wound until it heals fully. But you want to cover a wound in such a way that there's still some air that can breathe, right? So it's not about like wrapping something so much that you don't look at it for 2 weeks. You want to make sure that there's some oxygen getting in there in order to facilitate fibroblastic action. So to actually close the wound, right? The cells that close the wound need some air. Okay. When you're assessing wounds, color is key. So a black wound means that there's a lot of dead tissue. Okay. And then wounds that are yellow, it's helpful to consider temperature, because yellow we sometimes think of as a pussy wound, but there are times when new granulating tissue can present as yellow. So it's helpful to do an assessment of the area. Is it very tender, right? So is it how tender is it to touch like around the wound? Do you smell anything? And is the area warm? So moving from red, this red yellow threshold is a wound that can be either happy and healing or a wound that's going towards infection, right? So it's going to be helpful to get a full picture and to gather as much information from the patient as possible. A red wound oftentimes is more of a fresher wound, and also can be a wound that's healing and happy. And that going into pink wounds too. So I find that it's helpful to think of basically yellow, black, definitely needs attention. Black can also be, like I had a patient who came into the clinic yesterday who has a black fingertip because she had a hematoma, or she had broken her finger, but then like underneath the skin was some blood that had collected there. So in her situation, we asked the doctor, hey, this it's black. What do we do? So um, he then told the patient to keep it very clean, 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 because it turned out that she hadn't been washing her finger as much. She had just put a splint on and she just ignored it. Yeah. So it's very important to educate patients that keeping things clean and dry um, can be very beneficial. So clean and dry in this case is not a wound that's on the surface. It's just a matter of keeping the area clean and dry, which is not to be confused with keeping a wound, an open wound, moist enough that it can heal properly. Okay. Assessing a wound. So as I had mentioned, wound care is a pivotal part of what I do. This patient does have an infection. One key thing that notified us he had an infection was that this finger here is very swollen and very painful, right, in the line of the wound. So, the wound did have a smell, right? So I know, and then conversely, this wound here has some yellow, but is actually a happy wound. Yeah. So an assessment of this wound would be, what does the area around the wound feel like? Is it tender? Is it warm? Is there a smell? Yeah. This wound, the doctor was very happy with, had no issues. This wound, this patient ended up needing antibiotics and further intervention to heal the infection. So, as I had mentioned before, a full comprehensive assessment of the site is important. This patient up here, it can be hard to tell from this picture, but their wound was actually a little macerated. And this is what it looked like before I cleaned it. So sometimes it can be helpful. I used some sterile saline, a mix of sterile saline and peroxide to clean this area. Straight peroxide is too harsh. So straight peroxide, which a lot of times patients will kind of like dump on their hand, dries out the healing tissues uh, and kills them off. So I find when I'm dealing with a situation where this surgical incision isn't fully healed, I find using my preference is to do about 90% sterile saline and 10% peroxide. So basically it'd be like a cup of sterile saline and I put some drops of peroxide in and I use that to clean this area. And then I instructed the patient on how to do that himself and to air it out. Because again, it's hard to see from this picture, but this area was looking a little gray, which told me that it was too moist. And so the wound would have a hard time closing more fully because the tissues were not having a chance to knit together because there's too much moisture there. Things to keep in mind, how long has the wound been open? What do the edges look like? So the edges of this wound versus the edges of that one. The edge of this wound is crusty and pussy, and also the finger is very swollen and tender, versus this looks like the edges are kind of knitting together very nicely. Is there drainage? Is there a smell? Is the area warm, red, purple? Purple would be somebody who's my skin tone. I'm fairly dark. If I'm having what might look like redness on somebody who's light would look more purple or dark brown on somebody who's my shade. So thinking also about the skin color of the patient can be helpful with assessing the area. Cleaning a wound. So one of the surgeons that I work with prefers plain soap and water. No fancy creams, no fancy soaps. Now, I'm aware that getting access to clean water can be not so easy. So I was looking up ways to create clean water, and according to the Centers for Disease Control in the US, water heated at a rolling boil for 1 minute is microbiologically safe. So one way, if you have access to a heat source and water and a vessel to heat the water, would be to boil it to make it clean enough that you can clean a wound. You want to limit disturbance of the wound bed as much as possible when you're cleaning out debris. So it's not a more is better situation. You want to make sure that you're respecting the healing structures. It is possible if you don't have a sterile. So in the clinic, I have the luxury of these sterile suture kits that come with like a little tweezers and a little scissors, and I know that they're clean and sterilized. It is possible to use a flame to sterilize a sharp instrument if you're planning on cleaning a wound. The reason why you would want to clean a wound is because, again, you need oxygen for the wounds to heal optimally. If a wound is covered in layers of dead skin above it, the wound is going to stay open for longer, which will increase the chances that it will get infected. As I mentioned before, hydrogen peroxide can be pretty harsh and will harm delicate healing tissues. So if it's possible, dilute it 50-50 for an active infection if you're cleaning the wound, or 90%, 10% for gentle cleansing, as I mentioned before. Okay. Wound dressing. So different types of dressing. I'm not sure what people would have access to. A very simple rule of thumb is to use gauze, sterile gauze or bandage roll. I like those because it allows for some air circulation, right? The downside is it can stick to a healing wound. So one way to deal with that is if you have access to some Vaseline, clean Vaseline, is to put a thin layer of Vaseline and then put the gauze on, because then you won't disturb the healing tissues by having the gauze that sticks to the wound. So that's a very basic rule of thumb, because there are some dressings on the right side of the screen to keep in mind that do not stick to the wound. Tricky thing is, people may not have access to those, but it's very important for you to be aware that they exist, right? Non-adherent dressing. So again, you don't want things to stick to the wound. Their brand names that we use, Telfa and Adaptic, are some non-adherent dressings. That Telfa is a non-adherent pad, doesn't have any ointment on it. Whereas a non-adherent wet dressing would be something like Adaptic that does have a bit of wet on it that you can use for treating wounds. Okay. One of the surgeons I work with, another surgeon, has treated some injuries in Ukraine, I believe. And so I asked him what he thought it would be helpful for therapists to know. And he mentioned taking care of pins or external fixators. So most of the cases that I see, people have had open surgery, so an open reduction internal fixation. So they have the screw and plates inside, and then the incision is outside. But there are times when it is the quickest way for the surgeon to deal with the situation in areas that are under-resourced and in times of crisis is to externally fixate, right? So you put the structures on the outside and you have pins that stick out, right? Especially when the wound is more complex. So I'll see external fixation, especially for the finger, with finger fractures that are like a bunch of little pieces. Something like this, you would see more in this distal radius fracture fixation would be more in a time when you either don't have access to open surgery or it's the best, quickest mechanism to use. Taking care of pins, some surgeons, again, prefer plain soap and water. I find if you're, for an abundance of caution, you can again use a 50-50 sterile saline peroxide solution to clean around the pins, because we don't want them to get infected. Yeah, there's a piece of metal sticking out of the body, and these are potential infection sites. So the tendency might be to want to put a bunch of, for example, Neosporin antibiotic cream on there. You want to limit how much you gunk up the site or put a bunch of residue on there with ointment or cream. You want to keep the areas clean and dry and clean with like the sterile saline and peroxide. That's the best way, especially in environments where there's a lot of germs around and it's an uncontrolled environment. Having them clean with the sterile saline and peroxide is a good strategy. Okay. I'm going to pause here for a moment and see if there are any questions so far.
I can't see any question. I guess
Okay,
it's,
sure. All right,
yeah.
thank you. Alrighty. So, as I was mentioning earlier, why would you clean a wound? Well, you would clean it in order to get also, this is a patient who had surgery, and these are the surgical incisions, as you can see. This is what he looked like when he came in, right? There was a bunch of dry tissue and dead tissue on top of the wounds. So, what I did was I used my sterile, sharp instruments to take off all the dead tissue. Let me see if I can move this so you can see. Yeah, so he had a bunch of dead tissue all through there, okay? And so I knew that in order for these parts of the wound to heal, so I didn't touch these actually. All I did was remove the dead tissue on top so that these could heal properly, right? Now, it's important to keep in mind that if the patient is diabetic or a smoker, healing will be slower. So the graphic I showed earlier of the phases of wound healing, if you notice that the patient is healing much more slowly, it could be because of a lack of nutritious diet, right? Because your body needs nutrition to heal, but it could also be because they have diabetes or because they smoke. Those will affect wound healing as well. Yeah, cleaning and debriding the wound is very important. Oops. Mm-hmm. Oh, there we go. Okay. Scar management. This is not the best example of an adherent scar. This is, pretty nice looking scar. As I had mentioned before, when wounds heal, the tissues, let me pull up my visual again because I'm demonstrating. The tissues heal and they knit the area back together. But the collagen fibers that close your wound tend to be pretty chaotic. The way I describe it to my patients is you go from kind of nice, orderly layers of skin to a pretty chaotic layer, kind of top two layers up top. So if you educate the patient to massage the scar, you can kind of flatten out those layers a little bit so that when they move, they're not getting stuck in the scar fibers. Yeah, because when you move, your skin needs to move. And a scar that is not mobile affects the joint motion underneath. Also, a scar that is not mobile, that doesn't get massaged and mobilized to break up those chaotic collagen fibers, tends to be hypersensitive. So patients will complain that it's burning or that it's painful. So it can be helpful to show them how to massage a scar so that they can calm down the nerve fibers that might be attaching to the scar tissue and affecting their ability to use their extremity. Okay. I'm going to move on to fracture healing, a review of the bones of the upper extremity. We have the shoulder blade, humerus bone. This part of the humerus bone here, it tends to be where the radial nerve, there's a spiral groove of the humerus, which isn't shown here. The radial nerve will run through that oftentimes. So if a patient has a fracture of the humerus, you might again have the incidence of wrist drop, right? So wrist drop can occur with compression and also with a fracture of the humerus bone. So you want to do an assessment to see how their wrist extension is, how their elbow extension is, because the radial nerve might be affected. The epicondyles of the humerus, and then we again have the radius bone and the ulna bone. The radius bone is on this side of the forearm, the ulna bone is on that side. And the radius bone tends to rotate with the arm. So if I go this way, my radius bone is pretty straight. If I rotate this, my radius bone is on that side. Okay, so, and then we have the carpal bones as well. The scaphoid bone here is the slowest healing bone in the wrist, has the least amount of blood supply. So if you're in a situation where a patient is diagnosed with a scaphoid fracture and they will not have access to surgical intervention, or they do have surgical intervention, it's going to be important to immobilize and keep the wrist still while the bone heals. Because the scaphoid bone is located, basically, if I were to draw a line from my thumb into this area here, I could kind of poke at my scaphoid. So it can be helpful to include the thumb in whatever splint you're making for a scaphoid fracture, just to make sure that the thumb motion isn't affecting the bone healing there. Types of fractures. Displaced fracture is when the bone breaks into two or more pieces and moves out of alignment. A non-displaced fracture would be something like this, where the bone fragments are fairly in line. A closed fracture where the skin is not broken, and then an open fracture where the bone is piercing through the skin. It will be most critical. There's risk of infection. The bone fragments are out of place, obviously, and getting care for that person is pivotal because we don't want infection to set in. We don't want bone healing to set in with structures and bone fragments that are out of place, because when that happens, and if bone healing starts with displaced pieces, usually they will need to be rebroken and put back in place later. Okay. Stages of bone healing. Bone healing, it's helpful to think of it as 4 to 6 weeks for bone tissues to, knit together and get to a place where they can start to support a little bit of weight. Yeah. Weeks 1 through 4 are pivotal times. If it's possible to protect the patient's extremity while it's healing with a splint, and to educate the patient on limiting putting any weight on it, lifting heavy objects while the bone is still healing. The bone will develop a bit of a callus. So oftentimes when bone heals, people say, oh, why do I have this lump? It's because, well, your body laid down new bony material, and it's not going to heal in a very flat, perfect looking orientation to the other side, right? It just means that your body laid down some bony callus material. Factors that are going to affect healing of bone: excessive movement and malalignment. So that's where your splinting comes in and your patient education, because if you're able to place the patient in a good position, then that limits the excessive movement that would affect their ability to heal the bone. Soft tissue damage and soft tissues that are caught within the fracture site can also affect bone healing. It would be hard for you to catch this in the field, but if they're able to get the fracture assessed and also to get the fracture reduced, so to be realigned in a way that doesn't trap the soft tissues, that would be pivotal, obviously, and most important. Amount of bone comminution and bone loss. So bone comminution, in this case, we mean how many pieces of fracture are we talking about? How many bony fragments? And how well were they put back together? That's going to affect bone healing. In times of crisis, getting nutritious food is obviously a problem. So ability to eat food that has the appropriate vitamins and minerals will affect bone healing. Age will affect bone healing. Also smoking, but smoking affects bone healing as well as wound healing. So I know that I said the bone takes 4 to 6 weeks to heal, but in times of crisis, it would be prudent or wise to extend that timeline in a little further, to be cognizant of the fact that you're not dealing with kind of optimal conditions, and to account for that when you're thinking about how long it would take the bone to heal. Okay. Okay. Fracture fundamentals. So the soft tissue around the joint needs to be placed in a position of either length or just like a neutral position, so that in the future things can heal properly. So if you have a situation where a wrist is not supported and it's healing and it's in this position, it's going to greatly affect the patient's ability to actually use their hand down the road. I'm going to talk more about the intrinsic plus position later, but our inclination after a fracture in the hand is to straighten the fingers and straighten the hand like this, but it's actually going to be better to place the patient in this position. Mainly because the ligaments in these joints that when you bend get lengthened. And that means that down the road, when the bones are healed, the patient will be able to actually, do things like make a fist. If the patient is placed in the straight position for that 4 to 6 weeks of healing time, getting them to make a fist is very painful and very challenging and often requires surgery in order to free up the joint contractures in order for them to move. So better to place them in a bent position at the metacarpal bones here. Sure. I see that someone raised their hand.
Yes. Let me see.
Sure.
I guess he's
It's still raised.
no,
Okay.
no.
Okay.
But I can see some comment in the
Okay.
queue.
Okay, gotcha.
Yeah.
Alrighty. There we go. Oops. Let me make sure I don't miss anything. Good. Okay. Tendons. Tendons connect muscle to bone. So this is a tendon here. And tendons are kind of how I describe them. Let me move this guy. Oops. 1 second here. Move this up. Tendons are I like to describe them as the ropes or the cables that move the joints. So on the palm side, you have your flexor tendons that flex the fingers, 2 per finger. And then on the back, you have the extensors. It's usually pretty easy for me to show you what my extensors look like because they're these ropey things here, and the extensors would extend my fingers. And then all those muscles are down here. So I have my muscle here that attached to the bones at my epicondyles. Then the muscle transforms into the tendons that facilitate the motion. They're the ones that transfer muscle power to joints, as I mentioned. They require motion and gliding or excursion to be healthy. They're very delicate. When I was a student, I learned that it's like a piece of spaghetti, right? So after a patient gets a tendon repair surgery, we say, it's like fixing a piece of spaghetti, very delicate, and you want to be very respectful of it. Flexor tendons bend the fingers on the palm side, extensor tendons straighten the fingers. Sorry, my presentation sometimes doesn't respond. Okay. So tendon fundamentals. Let's move this down. Flexor tendons. For flexor tendons, in the event that you are dealing with a patient that was able to get a flexor tendon repair, the worst risk of rupture or damage to the tendons is in days 5 to 21. So that's when the scar tissue starts to kind of build up around the tendons. As your body's healing, it sends a bunch of protein-filled fluid to the site and starts to knit things together. So if you apply too much force and too much traction too quickly, then you risk injuring the repair. And paradoxically, you also still want to keep moving it to keep them lubricated, right? And we need to be protecting them from excessive tension. So because these are your flexor tendons, if the tendon extends all the way, that's too much stretch, right? In the instance of a repaired tendon. So you want to make sure we're placing the patient in what we call a safe position so that we can educate them on how to move in a position or in a range that doesn't place too much tension on the flexors. There we go. Okay. Flexor tendon protection. This is the position I was talking about. This would place a patient in a position that would avoid excessive tension on those flexors, right? These metacarpophalangeal joints would be flexed. And then we're trying to extend these interphalangeal joints here because they have a tendency to get stuck in a stiff position. So again, similar to that intrinsic plus position I was talking about before, we're trying to make sure that we keep the structures on stretch that need to be placed in a stretch so that eventually we can do a nice fist. Okay. You can also use this position to treat nerve injuries, right? It's just a good position to be aware of, right? If you're in doubt, if you're in a situation where you're like, I'm not fully sure what structures are being affected here. This can, and you know that it's not an extensor tendon injury, right? Because an extensor, if the patient cannot extend their fingers, that's when you want to keep things straight. If it's any other situation where you're like, you know what, I see some lacerations, I'm not sure, and the patient is saying, oh, I feel numb, or it's a situation where there's injuries to the front side of their hand, it can be helpful to just do this as a rule of thumb, placing them in that safe position until they're able to get further intervention. That can be very helpful. Okay, so tendon mobilization, right? Protected mobilization. So this patient is within the splint that I showed in the previous picture, but they are using a protocol where basically, let me shift this over here, where in week 1, they would be using their other hand to provide a stopping point for them. So within the safety of the orthosis in week 1, they're focusing on bending the fingers to the index, the injured fingers rather. So in week 1, they're bending the fingers to the index. In week 2, they're bending the fingers to the long finger or the middle finger. And then in week 3, they're focusing on bending the fingers to the ring finger, finger number 4. So this isn't meant to be a tutorial. It's meant to just show how structured this rehabilitation process can be, right? So we're trying to start to glide the tendons in a way that's protected and very strategic so that we can facilitate motion down the road. Okay. Extensor tendons, right? Opposite situation, back of the hand. Sometimes it's helpful to straighten, place the hand in a position not where all the fingers are straight, but when you know exactly what finger is affected, you can place that finger in relative extension to the other fingers, so that then it's only the injured extensor tendon that's being placed in a protected position. These pictures are from a paper where they were treating extensor tendons like in an ER, which I thought might be, more applicable to a situation where you don't have a lot of resources to place a hand patient in a fancy splint, for example. And in this situation, we're placing the wrist also in extension, so we're not putting any tension on the extensors, right? So again, we're dealing with the opposite problem than with the flexors. With flexors, you don't want them to extend. With an extensor tendon injury, you don't want them to flex too much. Yeah. So if you're confused about which finger it is, keep everything straight with an extensor tendon injury. Same principle of only flexing so much that you are gliding the tendons without having them stretch the tendon out fully. Yeah. It can be a very frustrating process, but the more you can respect the tendons, so kind of finding, looking up the ranges of motion that are acceptable in X amount of weeks, the better outcomes your patients will have, because you're respecting the healing structures, but still giving them some motion to keep them lubricated and nourished. Okay. Same thing as with flexor tendons, the worst risk of rupture is in days 5 to 21 if you're dealing with a tendon that was repaired. This is another good example of showing the wrist place and extension, and then the affected extensor tendon place and extension of that finger. There are also zones And within each zone of the flexor and extensor tendons, that can determine what position you place patients in. With this presentation, I'm trying to focus more on like broad general principles that you could apply to optimize the outcomes, keeping in mind that sometimes you will have the option of doing more in-depth research, and sometimes you don't have that option, and you have to kind of apply a general rule of thumb and take it from there. Okay, next we're going to talk about burns. So there are different types of burns. First degree burn is superficial, some redness of the skin without blisters. Second degree burn, there is some skin damage and blisters present. And third degree burns, full thickness burn. And then also with these, there can be no pain. So earlier I was talking about how pain can be a very helpful red flag, but when you don't have pain, yeah, the tendency might be to think that, you know, everything is okay. But these instances start to move into, you know, substantial damage of structures such as tendons, joints, and bone. So, in the case of first degree burn, some follow-up care fundamentals to know. First degree burns, pretty superficial, treated with a local painkiller, so usually heal within a week. Second degree burns and blisters can be, you know, the hand can be splinted in a position to prevent stiffness, you know, especially if it's blisters that need to heal. And if there are some wounds there, keeping it clean, changing the dressings frequently so that you don't get a collection of drainage on the gauze, for example, would be good. Applying antibiotic creams. Again, you don't want to apply so much that you impede air circulation, right? Healing within 2 to 3 weeks usually. Again, keep in mind with all these timelines, you want to account for poor nutrition because that's going to affect how long it takes things to heal. Okay, for the third degree burns, dead skin will need to be removed. As I mentioned before, dead skin is never a good thing to sit on a wound because it'll impact healing speed. And then if the person does have surgery, placing the patient in a position that limits the skin kind of getting stuck together, basically. I think I have a slide of that. Here we go. So with a splint like this, we're keeping the fingers separate. So you don't, and again, because sometimes with burn injuries, you end up with the fingers kind of webbed because the skin layers are impacted so much. So this maintains tissue length, okay, so that later on, I mean, it would be regaining flexion is challenging, but at the same time, you're placing them in a position that they're not getting stuck with fingers like that, yeah, while things are healing. It's going to be better to rehab from distinct fingers than from a place where the fingers are kind of stuck together and then they need more surgery to separate the fingers so they can move, okay? Sometimes placing the hand around an object such as that can be a good way to get them into that safe position, right? If you don't have the fancy materials to, or if you know, don't have access to an immobilization material to use, you can, you know, keep their hand around an object. That's one way to do it too. That can be helpful. So another example of a splint that can be used for burns too. Again, placing that hand in that safe position. And the thumb, it's very important to keep that web space open. Yeah. So in this splint up top, you see that the fingers are separate. If the burn is anywhere near the thumb, also want to make sure that the thumb web space is kept open so that eventually they can use their hand. So you never want to leave a burn hand sitting flat and squished together like that. Another key component of these situations is the psychosocial impact of injury, right? So these are very traumatic situations. It's a traumatic, you know, even without being in an area of crisis. As a hand therapist, I often have to provide my patients with this space where they can, you know, cry and rant and complain about how hard things are, because it's very stressful to not be able to use your hands and to do what you need to do. Much less in a time of crisis when you're dealing with displacement and other traumatic situations like loss of family members. So the factors that are going to influence the psychosocial impact of the injury on function would be severity of the injury, amount of pain. If they're in pain all the time, it's going to be very hard for them to think and function. Will affect, how much they can process what you're telling them about how to take care of their hands. How the injury occurred, was it a bomb blast injury? What did they run and fall? Those will affect too. Lack of social support, so lack of family members around means lack of support for rehabilitating from the injury. Limb dysfunction will also affect, so inability to use the extremity to do what you need to do will affect them emotionally as well. Impact depression, anxiety, neglect of the injured extremity. So sometimes what patients do is just avoid looking at it, avoid using it. So, if you say, hey, I want you to do these exercises and to massage your scar, they don't want to touch it. They just don't want to deal with it at all. But the downside is then eventually they have less and less ability to engage with the extremity. Sometimes patients would say, it feels like it's not a part of me. It feels like the extremity is not a part of me at all. And so in those instances, I tell them to, I mean, gently, I encourage them that they have to touch it. They have to kind of reacquaint themselves with the extremity to make sure that it stays integrated as a part of themselves, um, which can be very hard to do, but it's very important that they not neglect it and not kind of ignore it and pretend it's not there. Withdrawal and isolation can happen too because you feel uh, a sense of being separate because you're not able to function like everybody else is. Anger, very common, especially when things are taking longer to heal, when you're not able to do what you need to do. PTSD, especially in times of war, but also we have patients who, if they sustained a fall, um, will get very distressed when they talk about the fall. And so that will affect their ability to participate in the recovery process. So accounting for these factors and not simply focusing on protocols of like wound healing and exercise and it's all a part of the process as well and will affect how successfully your patients recover. Our role as clinicians will be timely intervention, which I'm hoping that this lecture will help to give you some ideas of what interventions you can apply in the early stages of recovery, to listen to what the patient is saying, acknowledge their feelings, acknowledge the circumstances. Sometimes it's simply about saying, that's horrible, that sucks. Finding connections. So either finding connections between you and the patient or helping them to find connections in their community or to, depending on the context, what resources might be in their environment that they can have access to. Following up and following through. So I know that in times of crisis, it's going to be much harder to, in my practice, I can simply call up a patient, in a few days and say, hey, how are you doing? That's not always possible. So if there are channels where that is possible and feasible to do that, and when in situations where you are able to either correspond, so if you know the patient is going from this camp, for example, to another camp in a different area, is there a clinician there that you can reach out to so that they can look out for that person and keep an eye out so that they can check in with them? I find that patients, sometimes they just want to know that other people care. Um, and if it is feasible and you are able to facilitate that for them, that makes a huge difference in their recovery process. Simply feeling heard and seen can be very helpful. Okay. A fellow clinician had mentioned some outcome measures. So, ideally, you'd be able to measure the impact of your interventions, or just if you were having the luxury of seeing the patient for a few months, to assess where they are in the beginning and the end of treatment. Yeah. I'm not referring to in this presentation, um, outcome measures such as like the quick dash or the dash, because these and other ones are ones that we know as occupational therapists or physical therapists. I picked these two because my colleague mentioned them and I thought that they're helpful in times of crisis more specifically, because this one so addresses cognition, which can be affected by times of crisis. Negative affect may get into anger, depression, pain, stress, and coping. I'm presuming in these situations that it's a stressful situation, yeah. So figuring out a way to assess that. Another one that my colleague mentioned was the Tampa scale of kinesiophobia, which I believe is used oftentimes with athletes, but I find, or people who engage in sports activities, but I thought that because it deals with a fear in the outline of the outcome measure, it talks a lot about fear. And I was thinking in times of crisis, fear is a huge factor in our ability to function. So I think that this is a great outcome measure because it talks about and tries to measure the debilitating fear of physical movement and activity, because you're in a state of feeling vulnerable. You're in pain, you're fearing re-injury either by, the next bomb that's going to drop or next falling object that, it's a pretty strainful environment. So I feel that an outcome measure that tries to quantify that is helpful. So that's why I like these two interventions, outcome measures rather. Did I miss anything? Yeah. So factors that will affect recovery in wartime would be nutrition, as I've mentioned before, poor healing due to starvation and vitamin deficiency. So bone healing timelines, wound healing timelines are going to be affected by this. Sleep, positional impact on upper extremities. Patients will often develop ulnar nerve symptoms from sleeping with their elbow bent. If you're in cramped conditions, you don't really have the luxury of putting your arm the way that you would like to. Some patients will develop radial palsy or wrist drop from sleeping on their humerus, on their upper arm. Air quality, so poor respiratory function will affect, your ability to get sleep, your appetite, ability to get the nutrition that you need for optimal healing. Hygiene, lack of clean potable water for cleaning wounds and for hydration will impact recovery. Accessibility, so if you lose lower extremities, if you lose an upper extremity, you're less able to get around, less occupational participation as a result. And then disease. If you're dealing with an infectious disease outbreak, you're much less likely to care about doing the exercises that your therapist gave you to do to optimize your function. So it'll be important to keep those in mind and to factor that into your intervention designs and how you approach the patient. Okay. So this is more as a summary. Rehabilitation fundamentals: prevent infection, reduce edema or swelling. Swelling means stiffness and means impaired motion. So you could compress by using, sometimes there are wrapping strategies that you can utilize for hands. Sometimes it's just about teaching them tendon glides, for example, managing pain, promoting healing, prevent deformity, using splinting or appropriate exercises, and then maximizing motion while protecting the injured structures. The managing scar tissue and hypersensitivity. Scar management is something that's often overlooked, but as I hope I've illustrated, managing the scar is an important part of recovery and joint mobility. As far as splinting strategies, it's important to think of alternatives, yeah, because a lot of times when you look up splints on the internet, you see fancy thermoplastic material. In order to use those, first you need to have the material, you need to have some Velcro and straps, you need to have a hot water bath at 155 to 160 degrees Fahrenheit. Not, not necessarily going to be feasible. So you could use a towel with a strap or rope for maintaining hand safe positions. If I rolled up a towel and placed it on my hand, I could facilitate a safe position after a tendon repair bone, and also help to preserve the palmar arches. So those are the arches that, that your hand, that's why your hand kind of rests in this position, because that's the optimal position for functional biomechanics. You could use cardboard to make a resting hand or finger extension or finger, piece slots of cardboard for finger separators. If you have stiff enough cardboard, you could use it to make an anti-claw splint so that you could take the patient from this clawed position to more of that position so they can actually use their hand and not be stuck in that claw position. You could use a pair of pants, thinner material, to make a sling after a radial head fracture. So radial head would be elbow fracture. You could use a belt to just make like an arm support to keep, because if you have a traction injury of a nerve, right, and the arm kind of gets, shoulder socket kind of gets traction too much, you could use the belt to kind of brace the arm, right, and to keep alleviate the tension on the brachial plexus. Okay. So the orthosis should be appropriate for the diagnosis, comfortable, supportive, as comfortable as you can make it, obviously. Should not create pressure points because that'll lead to pain and can lead to new wounds. Should not impede circulation. So if the patient's extremity turns white or pale, in my instance, for a darker person like me, I might look a bit more gray. Then you'd want to adjust the strapping so that it's not cutting off the circulation. And should not trap swelling, right, which is also related to circulation. One moment. Okay. So signs of poor immobilization, as I have mentioned some of, pressure wounds, so a wound from too much pressure points, bony prominences such as the ulnar styloid, radial styloid, olecranon, bony part of the elbow here, and also the pisiform bone, which is right on the side of your wrist, right on the pinky side. That can be an area of pressure and friction. Pallor, so blue or pale tinge to the skin. Increased numbness is a sign that something's too tight. Increased tingling means your nerves are getting squished. Heavy sensation, so the arm feels heavy. Throbbing, a sign that circulation is getting impeded also. Increased pain. Steps that you can take to address that would be to loosen the straps, remove the orthosis, reconsider the design, and also check in with the patient periodically if that is feasible. So, resting hand orthosis, I challenged myself to try to make something if I was in a pinch, right? And I needed a way to keep my patient in a safe position while I was waiting to get them further care. I challenged myself to make something out of cardboard. And then I kind of folded a piece of cardboard here to keep that web space open. Now, ideally, I would use some straps. I challenged myself to not use more things. So ideally, I mean, these are some hair ties and I happen to have a rubber band, but ideally I would put some strapping on here. And this would be, and I wore it for about 30 minutes. So ideally the cardboard would be a little stiffer, and ideally I would not be using cardboard, but I did find it to be an effective way of keeping my hand in a relatively safe position. So that's one thought that I had. And in this, you can see that my wrist is in a fairly neutral position. It does keep my fingers straight. There would be the option of putting something else on the back because my fingers might start to curl. So I could place something on the back of my fingers to keep that straight too, to maintain that safe position until the patient could get further care. Okay. This is more of a breakdown of the intrinsic plus position, right? So it reduces risk of contracture. So again, if you have a patient with a metacarpal or phalanx fracture and you keep them straight, they will get contracted at these metacarpophalangeal joints. So placing them in an MP, metacarpal joint bent position is optimal. 70 to 90 degrees, if you have a goniometer and can assess that, or 90 degrees is basically an L shape, so you could kind of go backwards from there. IP joints, interphalangeal joints, you want them to be extended. Okay, you can use for metacarpal fracture, proximal phalanx fractures, digital nerve injuries, collateral ligament injuries. A collateral ligament and ligaments on the sides of the joints of the fingers. A volar plate injuries. So volar plates would be the fibrous structures on the front here. You can use it to keep things safe so that people don't hyperextend and strain that structure while it heals. So another thing I challenged myself to do was, if I didn't have many resources at my disposal and I was dealing with somebody that had a distal phalanx fracture, so fracture the top here, what could I do? So this was a piece of wood that I found, and then on the ground, and then these are actually from leaves. I did it on myself, so I didn't double knot them. This bottom one here looks like I could have gotten a double knot. It was actually fairly secure, and it kept everything straight, right? So I tried out moving the joint. If you were dealing with a fracture of this middle phalanx, you could simply, put it on the whole finger, just making sure that it didn't get in the way of this crease here, so I could still bend the rest of my, so I could bend the finger as a unit, basically, right? And it was actually fairly effective. So mallet injury, a mallet injury is when the finger, droops down like that. Oops, let me pull up so you can see. So mallet injury is if the finger just, stays like that. You could use it to straighten that, also for the fracture of the tip there. Buddy taping and strapping. So in instances where you're dealing with a, fracture of the finger, especially as middle phalanx, it can be helpful to attach the finger to the adjacent finger until you get further intervention. This was pipe cleaner that my daughter happened to have sitting around. So ideally I would, separate, these were like 3 pipe cleaners. I could have separated them and put, one up here, one down there, but I just wanted to test out how effective it would be to use something like that to secure, making sure it's not too tight, right? So if my fingers had started throbbing, then I would know that I had too much tension on there. Okay, so a sling, I made a sling out of a scarf that I had to see how effective that would be. So radial head fracture, again, elbow or shoulder dislocation, that would help keep my shoulder, because sometimes the humerus is kind of pulling out of the shoulder socket, would help to keep everything stable. And olecranon fracture, so fracture of the bony point there, would help to keep everything in place until you can get some further care. This was slightly silly, but actually strangely effective. So I found this piece of bark because I happened to be in the woods. And I thought, if you have a radial or ulnar shaft fracture, you don't want them to rotate at all. So I found this piece of bark and I thought, would this keep me stable? Would this keep me from rotating? And I was surprised to find that this piece of bark and charging cable that I happen to have in the car did keep me from rotating. And also, you can see part of it is on the wrist. Whoops. Part of it is on the wrist. And so it actually kept my wrist from moving too. So if you were dealing with a situation though, the person had a fracture here, a fracture there, and you wanted to keep everything immobilized, if I was in a pinch and I needed to keep that person stable and not rotating and not putting strain on the bones, it was actually effective. And then in the case of a humeral shaft, fracture, I scored So with the cardboard, I basically, scoring would mean like drawing some sharp lines, thin lines in the cardboard all around so that I could bend it into a cylinder. I was able to use that to place around my humerus. Again, ideally, I'd be using straps, but I was by myself and I wanted to challenge myself to make things that could stabilize and immobilize temporarily until I could get some future intervention. And it did a fairly good job of keeping things stable. So at the very least, if I had a fracture, uh, I wouldn't shift things out of alignment and risk injuring my radial nerve more if I happen to have a humeral shaft fracture. Okay. And these are some of my references. I was in a hurry when I put this lecture together, so this is not an exhaustive list of my references, but this is most of them. And you can always reach out to me via email for further resources, for more of my references. And I will be sure to email Nora a copy of this presentation as well, so that hopefully you can use it as a reference in your treatment. Okay, thank you everybody for listening.
Thank you so much. It was an informative lecture, and I really enjoy it, and how creative you are by doing these stuff. Uh, yeah, I really enjoyed it. Uh, if you have anything, you can write in the chat or you can raise your hand. I can see many thank you in the chat.
I want to, how do I stop share? Oh, there we go. Great.
Yeah.
Oh, sure. Thank you. You're welcome. Thank you so much.
Uh,
Any questions for me?
I think Furat have a question. Can you please raise your hand? Yes, I can see. Bayan. Yes. Yes, Bayan.
Hello.
Hi.
Thank you for this nice lecture. Actually, you are so creative at the end of the lecture. It was so interesting actually to use these things. I would ever never think about it first. I have actually a question about the skills you mentioned. You mentioned some of dash that we all of it we know it, but the other two in the slides, actually this is the first time I know about them. Can you tell us about them more?
Sure. Let me pull up. Let me share my screen again. And let me go to the, sorry about, you know what? One moment here. Give me a second.
Okay.
I'm going to, I think it'll be easier if I do it this way. So, Tampa kinesiophobia scale. Okay. So the Tampa scale for kinesiophobia, I actually hadn't heard of it until I had sent the lecture to a colleague of mine, and he because he knew that I was going to be gearing the lecture to people treating in times of crisis, he was the one who suggested it to me. So I'm going to write them both in the chat. So Tampa scale of kinesiophobia. And then there was also the pain catastrophizing. Oops. Okay. So these are the two ones in the chat. I put them in the chat just now that he had mentioned. And the pain catastrophizing scale, I believe, was designed primarily for people dealing with, let's see here, people dealing with chronic pain, well, with or without chronic pain, but trying to find a way to quantify levels of pain prior to intervention. So before you help them, you know, with whatever clinical intervention you're going to do, and after that. And then the Tampa scale for kinesiophobia was about movement. So fear of movement, fear of moving while at work, fear of getting hurt again. So in the situation where you're in a time of crisis, you're not working, but at the same time, there's a lot of fear. And so I thought that they would be really helpful in a time when fear is kind of the driving force behind so many things. Yeah. Like how do you measure it? And so I haven't used them yet in practice, but I was thinking that they'd be really good models to keep in mind. And I myself am curious to do more research into them to see how I could possibly use them in practice, or if I could help other people use them more.
Yes, I understood that. Yeah. Actually, this is the first time I listen about these two skills. I'm really interested to again to learn about. So if you don't mind, I will email you more
Sure.
to know about them.
Sure, and I'll
Yeah.
try to pull up as much information as I can and send it to you too.
Thank you for this. Thank you.
Sure, you're welcome.
Okay, any other question? Feel free to raise your hand or write in the chat or Q&A section. I can see Dr. Farouk said we always consult and seek help from dietitian to wound and burn in order to healing. In a sense, it's a multidisciplinary approach. What do you think?
Sorry, what did you say?
We always consult and seek help of dietitian in such a wound and burn for enforce healing.
Oh, yeah. So that's part of why I wanted to make sure that I mentioned nutrition, because that's a pivotal aspect of healing. And so I wanted to make sure that I mentioned that. I mean, I'm not a dietitian, yes, and I don't know what resources people would have, but it is a very important, having given people access to food, healthy food is going to be a critical part of healing. Sometimes gets forgotten about, right? Especially if you're just worrying about safety and in your life and death situation. But unfortunately, it is very important also to make sure people have access to that. And then it looks like Furat had a question.
Yeah, but I cannot see any
In the
hand.
chat. Do you want to type your question into the chat, or did you want to unmute yourself?
I cannot see anything. I would like to know your opinion. I'm working now in NICU, and I've seen cases that 32 weeks gestation age, and now it's 32 weeks gestation age or post-menstrual age, and the condition is like this. These two, yeah, mainly when babies stress doing like this, but he's stick this two finger in this one. I referred consultant, a surgeon, to know is it a nerve or a tendon. So I want your what do you think, and how we can manage this condition?
So how was the baby delivered? Was it C-section, or was it vaginal delivery? Do you know?
Vaginal delivery.
So I know that when the baby's being taken out, sometimes there's traction on the brachial plexus. And that can lead to neurological conditions. There's I think there's Erb's palsy. Look at those. Let's see here. So I mean, which is more weakness in the arm or shoulder that happens during birth. It's interesting that it's just the two fingers, though. one thought is to there's also, so there's an Erb's palsy and then there's Klumpke's palsy too. I may type those into the chat. So which are both neurological positions, neurological conditions that are influenced by, you know, how the baby comes out. So those are my first two thoughts. And I'm trying to see. Okay, so it looks like Klumpke's palsy. So Erb's palsy is more shoulder up, like kind of higher up, and then Erb's palsy is kind of more. Erb's palsy is more higher up, and Klumpke's palsy is more lower down. So in that instance, I think positioning would be helpful because you want to be able to position the fingers that are drooping. So kind of like a flattening the hand would be helpful. And then also doing some educating the parent to do some mobilization of the hand would be good. Commonly it's nervous conditions, it's closer to contractile tissue. Not it looks like Dr. Farouk had some thoughts on it too. Because he's saying it's mostly nerve conditions. I don't understand the last part of the comment, but let me type those in here though.
Okay. Well, thank you so much, Dr.
Sure.
Fatima.
So those are the two ones that I mentioned, which are both neurologically and birth mechanism influenced. But since I don't deal with pediatrics as directly, I feel like I'm not as informed about them. But that might be two things to look up, the Erb's palsy and the Klumpke's palsy, because you might see a patient later on that has more of the shoulder thing, which is the Erb's, you know.
Okay, so much.
Sure.